Good afternoon, friends. We're going to start this session on Macula Decoded, and I'll request Mallika Goel, you are on the co-chair, you have to be here. Ajit Babu Maji, then Siddharth Madan, then Srinivas and Tinku Bali. So whosoever are there in the hall, please join me here on the stage. And we'll begin right away because we are late 20 minutes. So we'll begin with the Octa, OCT and Geography by Dr. Ankur.
Can I have my slides, please?
Yeah, Ankur.
I wish to thank Scientific Committee, AIO Scientific Committee, for giving me this opportunity. And very good afternoon to you all. So I'm going to talk about OCT angiography. OCT angiography has been now with us for years. So we all know that OCT angiography is a nascent, fast, dye-free, non-invasive technique to visualize and assess retinal and choroidal vasculature abnormality. It provides us cross-sectional and en-face images to detect structural abnormalities, perfusion abnormalities, and vascular flow abnormalities. Unlike FFA or ICG that treats retina as a unilayer, OCT angio can detect blood flow abnormalities in superficial, intermediate, deep retinal capillary plexus, as well as in choriocapillaries. So then there are diagrams in OCT. What is en-face? En-face is 2D representation of the 3D volumetric data. And different layers of the retina can be are identified as segments, and area between each segment is known as slab. If you move the eye during examination, there could be motion artifacts seen as jagged lines. There could be projection artifacts when the superficial vessels are seen in the deeper layers of the retina. Then there are flow, flow void, and flow indices. Why do we need these diagrams? Because they can act as a quantifiable variable. One of them is foveal avascular zone area, acircularity index, how much your fovea is acircular than acircle. Vessel density, FD300 is foveal vessel density in a 300 micron area centered over the fovea. Perfusion density, an extrafoveal avascular area. This is an area of avascularity or flow void area outside the 1 mm area centered over the fovea. So what these quantifiable variables help us with, Rakausis and et al. Suggested that FD300 can act as a sensitive biomarker to detect subclinical diabetic retinopathy, while extrafoveal avascular area in superficial capillary plexus can discriminate between a patient of no diabetic retinopathy from a patient of NPDR. While vessel density, decreased vessel density can be a marker to the patient developing PDR. So in our study and a study by Bailey et al., how did we differentiate between an NVD and collateral? Based on 3 criteria. So one is if you detect an abnormal flow in the vitreous. Second, if you see these, based on the morphology, if you see these rete of new vessels, and while the collaterals are meandering vessels, at the same time, these new vessels in NVD or in NVE are seen in the vitreous plane, while collaterals are best seen in the radial peripapillary plane. OCT angio can clearly demarcate, delineate, and detect all types of CNVM. At the same time, it can identify subclinical CNVM, which are difficult to see on FFA because they don't leak. At the same time, if you see vessel abnormalities in different layer of the retina and you see a flow connecting all those 3, it's a lesion of a wrap. Just remember, segmentation is very important. Sometimes when there is a faulty segmentation, you can detect abnormal vessels which are not there. So faulty segmentation can lead to a faulty interpretation of a CNVM which doesn't exist in the patient of choroiditis. Always correlate your en-face OCT with the structural OCT because those flow void areas can just be a lytic space. They might not be a true flow void area. So look at the structural OCT with the en-face OCT. So OCT angio can also detect vascular flow abnormalities in deeper. So disease affecting the deeper capillary plexus like sickle cell maculopathy and paracentral acute middle maculopathy are better delineated on OCT angio. OCT angio can also delineate these NVs in patients of RVO, retinal venous occlusion. at the same time with the CNP areas. Treatment with the laser can be seen as reduction in the size of these NVs, at the same time reduction in the flow. OCT angio can also look at choriocapillaries. So these flow void areas in choriocapillaries in VKH, and resolution of these flow void areas can mark the time where you can stop the treatment in this patient. At the same time, we know that there are multiple white dot syndromes. So OCT angio can delineate by looking at the choriocapillaries that is this a multiple evanescent white dot syndrome, because these white dot syndrome do not affect choriocapillaries. So do an OCT angio in MEVWS and you will not find any flow void areas. Okay. Yeah. So with the availability of newer wide field OCT angio, the diseases that used to affect the periphery basically are also taken care of. So diseases like IRWAN, which we couldn't identify, or those peripheral CNP area that lead to recalcitrant DME, can also be treated with the help of OCT angio, because newer OCT can also look at the peripheral CNP areas. Swept source OCT has a better penetration than the normal OCT. So Brezina et al. Found that if they use swept source OCT based OCT angio, they can even delineate a retinal macular aneurysm, which was not seen with FFA because of the overlying hemorrhage. So because of the better penetration, you can look beyond the hemorrhages also using a swept source OCT. So then there are other places where we can use swept source OCT in chronic CSC to identify the CNVM complex, macular telangiectasia type 2, glaucoma to see the reduction in the blood flow around the disc, and the hereditary diseases. So what I would like to tell you all is, before doing an OCT angio, know the anatomy of the retina, know what you are looking for. Always look at the segmentation. Faulty segmentation, faulty results. Correlate your structural OCT with the en-face OCT, because one thing cannot be interpreted without the presence of the other. Use the right screening protocols. A 3x3 mm is a best suited protocol when you are looking at the fovea or the inner macula, while when you're looking at the wider field, like you are looking at the patient of an RVO or patient where you're looking for NVE, use a wider protocol like 6x6. In fact, now the montage of 14x14. Scanning is easy, interpretation is a bit difficult. So practice, practice, and practice and learn. Thank you.
Thank you. Very nice talk, Ankur.
Thank you, sir.
A couple of questions always remain with this high technology tool. There is a lot of fascination is using this, but taking it to day-to-day practice, everyday practice. Specifically, see, I'm talking about things like you said, abnormal and normal. A lot of times we discover those silent CNVMs, which are picked up. But do you treat them, or
Nope.
do you just observe them?
So observe them.
Yeah. So the endpoint is not known, even in routine CNVMs also.
So I totally agree with that, sir. Even today, the FFA is still the gold standard. I was discussing with Dr. Malaika yesterday that we can't see diffuse leaks. So if your patient comes to you with a DME of a diffuse leak, how do we see that on FFA? We can't.
Yeah.
So still today, the FFA holds complete value. But when we are looking...
So you made a statement that Octa can't replace FA.
As of now, it has not.
So what is the current role of Octa then?
So mostly the posterior pole pathology, especially ARMD, something when we are looking at the posterior pole per se. We are looking for any new vascularization. We are looking at any, we are looking...
Malika, do you do Octa in all CNVMs?
No. Initially we used to, but we found that it has no correlation with activity or treatment. So not every visit, we might, not at all. But I think more importantly, we use it to confirm the presence of NVD or NVE. We suspect there is a fine NVD. Not sure, then Octa can really show up the new vessels on the disc to add the laser.
I will not, because the thing is, to pick up a subtle NVE, you have to do a laborious job.
NVD,
it's not so. NVD is okay. NVD is okay, yeah. Because 5 minutes or 4 minutes of angiography will reveal more wealth of information regarding this rather than...
Only NVD I was saying.
No, Siddharth?
I totally agree, because FFA still is an investigation which is usually backstage. But I think FFA really is important, and it has an important role in the next talk also. So the role of FFA would be highlighted in the next talk also, where we are going to...
I think the learning curve still remains the biggest challenge, for a novice person. it does take quite a bit of time to, kind of.
I would just add that this can also be used.
Time is not far away, then we will not be making all these statements what we're making today, that it will ultimately come very, very close to FA. With the flow indices coming up and with the, this void zones coming up. So I think people have to learn all this so as to become adapted. As of today, most of us are not adapted and use it in everyday practice.
Two places. One, when we are looking at subclinical cases. Second, when we don't want to repeat an FFA, we can do an OCT angio. Thank you, sir.
Excellent pictures, Ankur. So now we have Dr. Chandramohan to tell us something about diabetic maculopathy. We have a couple of talks more also, diabetic maculopathy at the end by Ravi. So, yeah, there may be some overlap.
In one talk, sir. One talk is been changed on that. Little bit overlap will be there, sir. I pardon for that. Thank you IAOS and APOS for giving me the opportunity to speak on this topic on diabetic maculopathy. Diabetic maculopathy, whole array of changes that occur in the retina, vitreoretinal interface and in the surface of the retina. Intraretinal vascular permeability and vascular occlusion are causes for the intraretinal changes like macular edema, macular hard exudates and macular ischemia. Whereas proliferation and shrinkage of fibroglial tissue are the causes for vitreoretinal and preretinal changes like thickened posterior hyaloid epiretinal membrane, macular traction and other changes that occur in it. So diabetic maculopathy, once we talk about diabetic and macular involvement, only thing that comes in your mind is diabetic macular edema. So this talk is mainly to highlight that it is not only diabetic macular edema, there are a whole array of changes that occur in the macular area due to diabetes mellitus. Though diabetic macular edema is the most common cause. I quickly run few slides on diabetic macular since it is the most common maculopathy that we see. Any thickening within 2 disc diameters from center of the fovea, basically within the fovea, macula lutea or area centralis is called diabetic macular edema.
Do you still follow this thickening of? Do you still follow?
Yes, sir. I am changing. In the next few slides, I am just going to change what has changed in diabetic macular edema management. That is there in that, sir. People are totally forgetting what was there in diabetic macular edema management before. So I included a few slides in this. So increase in incidence with increase in stage of diabetic retinopathy, and also with the duration of diabetic retinopathy, hyperglycemic control, associated factors like hypertension, hyperlipidemia and other conditions. So the gold standard is slit lamp biomicroscopy, ancillary tests are angiogram and OCT. So I included this slide because this was during the era of focal laser. We used to break our brains to find out what is CSME, clinically significant macular edema. Area of thickening within 500 microns, radius from center of the fovea. Area of hard exudates with adjoining retinal thickening falling within 500 microns from center of the fovea, or area of 1 disc diameter falling within 1 disc diameter. So this used to be a big definition and we used to mug up and then we used to categorize this. Why we used to categorize this? Because when you had only focal laser, doing focal laser used to prevent 2-line visual acuity loss in these patients over a period of 3 years. So to prevent them losing the moderate vision loss, this criteria was very important. But with the advent of newer treatments, now prior to anti-VEGF intravitreal injections, the management was CSME, define macular edema as CSME. If it is CSME, do focal laser wherever possible and do PRP after that. But now with this was a classic management of a CSME case with focal laser. But now with the advent of newer intravitreal injections, now the definition has changed. Now we don't break our brain on CSME. Now what we see is whether it is involving the center of the macula or not. If the center of the macula is involved, still focal laser. If the center is not involved, then we moved into the pharmacological treatment. So this is center involved macular edema, cystoid macular edema involving the center of the retina, and this is cystoid macular edema with a serous retinal detachment. So if you have something like this, then we have whole array of agents that are injected to treat this. See, all the agents work well, and you can see the flattening of the retina with all the agents that are available. I am not going into details of it. So in case of diabetic macular edema, now if it is center in non-center involved macular edema, focal laser, center involved macular edema, treat with anti-VEGF or IVTA or dexamethasone steroid implant. This is the take home message. Next maculopathy is macular hard exudate. Wester report 8 and ETDRS report 22 have clearly shown that elevated total and LDL cholesterol is associated with greater severity of hard exudates in the macular area. So this is one of the cases of subfoveal hard exudates with diffuse macular edema. This is another case of severe exudative maculopathy. So Dr. Amod Gupta sir and et al. Have found that treatment of hyperlipidemia has a decreased incidence of macular hard exudates. So what you do if you have macular hard exudates? If you have a lot of macular hard exudates, do lipid profile. If the lipid profile abnormality is there, then there is no hurry in treating macular edema. Then you can treat the abnormal lipid profile with lipid lowering drugs and then can treat the residual edema. If the normal lipid profile is there, then you can jump in treating with macular edema with intravitreal injections or adjuvant added with grid laser. So the next maculopathy is macular ischemia. Dr. Shukla and me have published in IJO the clinical features of macular ischemia in diabetic macular edema is presence of multiple dot and blot hemorrhages in macular area, presence of multiple cotton wool spots, pale retinal edema, presence of white vessels, and visual acuity not corresponding to the edema. So this is a case with pale retinal edema with white vessel with abnormal telangiectatic vessels and the angiogram showing a severe ischemia. So we also reported the angiographic features in the same article, which says that if the largest linear diameter is more than 1000 microns with irregular shaped fovea, no capillary network abutting the foveal vascular zone, arterioles ending directly on the FAZ and dilated microaneurysms, then it is a feature of macular ischemia. What to do if you have macular edema and macular ischemia? So the main thing is, if you have macular ischemia, there is a high correlation with nephropathy. So screen for nephropathy. If you have nephropathy, then treat the nephropathy along with addressing. You can treat edema with macular ischemia with anti-VEGF, but not with lasers, which we used to do previously. So all other cases of maculopathies, like this is thickened posterior hyaloid with irregularity of macula. This is epiretinal membrane causing thickening of the fovea. This is a classic case of cystoid macular edema due to thickened posterior hyaloid, which is seen clinically as cystoid macular edema. These are the cases that are caused by fibrovascular. I'm about to finish. So these are the cases that are formed by fibroglial tissue proliferation. So for all these, the treatment is vitrectomy. For all pre-retinal vitreoretinal changes, the treatment is vitrectomy. See, this is a classic example of CME which resolves after vitrectomy. So to summarize, if it is non-central macular edema, focal laser. If it is central macular edema, treat with intravitreal injections. If you see lot of hard exudates, do lipid profile and treat lipid profile abnormality if it is present. If there is macular ischemia, screen for nephropathy, and if nephropathy is there, take care of the nephropathy. For all other vitreoretinal or pre-retinal maculopathies, vitrectomy is the treatment of choice. Thank you.
Thanks. You see, what do you do in patients who have dense plaques, hard exudates, but lipid profile is normal?
Yeah, then we have to go ahead with treatment of this hard exudate, sir. With intravitreal injections, either steroid or anti-VEGF, multiple anti-VEGF injections, sir.
So, no, you have to, either of them you will choose or one of them? Which
sir,
one?
my preferred choice is actually, if depends on the stage of retinopathy, sir. If I have a severe non-proliferative diabetic retinopathy with hard exudates, then I go with anti-VEGF, sir. If not, then I use steroids, sir, for this.
The other thing is, you describe treatment algorithm for hard exudates, macular ischemia, and CSME separately. But a lot of these may coexist also.
Yes, sir, yes,
Yeah.
that's correct.
So, why did you choose to describe them separately?
Sir,
Because
the
lot of
point for
times you
selecting
see,
this
because
topic is,
the reason I am saying Chandramohan is that DME is a complex pathology.
yes, sir, yes, sir. You have
see,
mixture of all this.
So,
This was directed towards
ultimately the management approach depends on 2-3 factors combined. What is the fundus picture, what is the visual acuity, what is the OCT, whether there is traction or not. And based on these three information provided, we choose a treatment pathology.
No, but when a classic picture is there, the algorithm will be followed. When the mixture is there, the experience will
Sir, why I choose this topic is, diabetic maculopathy was an essay question to me in MS exam, sir. I didn't knew what was diabetic maculopathy at that time. So I enumerated all the causes and then this.
Thank you, Chandramohan.
Thank
Now, if Mallika is ready, she will be.
Mallika, start directly. Why do you choose aflibercept?
Yes. Means so that it will be crisp and we will save time.
Because Chandramohan left us confused whether he said anti-VEGFs. So you don't have choice. You have to tell us you are propagating only aflibercept. So you are not using ranibizumab or Avastin or brolucimab. Mic.
Yeah.
Put on the
Can
mic.
you turn on the mic.
Slides, please. Okay, no.
So because there is so much data available now on
Yes, sir.
DME, so much data, anti-VEGF, steroids, so many, and Malika chooses aflibercept. Why?
Yes, sir.
Why?
So I'll just go ahead and show my experience with aflibercept, nothing more, no literature, except 1 or 2 slides maybe. So my experience with aflibercept in DME, and though it is a supported talk, it is totally based on patient benefit. So we know aflibercept has a high affinity binding to VEGF as well as PGF. And this dual action gives it very high efficacy, as well as there is a long duration of action in the vitreous. So initially we used to use aflibercept only for cases that were not responding to other drugs, including steroids. But then when we started using for these resistant cases, we realized a host of benefits. We saw the efficacy, the speed of response, and the longevity of response, which led to reduced treatment burden. And in addition, this all came with 0 adverse events of other agents. Raised IOP, cataract, inflammation, contamination, none of these are there. And then the anti-VEGFs also have the advantage over steroid of reducing the diabetic retinopathy severity score, the proliferative component. And so these are the first line of agents for DME management as per all international guidelines, anti-VEGF drugs over steroids. So these are my initial cases in 2017-18, where we used to come to aflibercept as a last resort. Now this is a patient in 2017, already tried ranibizumab elsewhere, so not working. We tried intravitreal triamcinolone because patient couldn't afford dexamethasone. And initially he responded to every 3-month IVTA, and then we required to give him every month because there was no response. But he stopped responding even to monthly. We wasted 1.5 years with monthly IVTA. Then he agreed to shift to dex implant, no response. In 2 weeks there was a recurrence. Again we wasted 6 months with 2 implants. And finally he agreed at the end of 3 or 4 years, he agreed to aflibercept, at which time there was an immediate flattening of the macula with improvement in vision to 6/18, which was a remarkable vision for him. And now we called him every month expecting to inject every month, but he required an injection only after 5 months. And subsequently, in the last 2 years, we have injected him only every 4 to 5 months. And from December 22, he did not require any injection till I just came in October. So 10 months interval. So the response was superior to dex implant. It was lasting for 4 to 10 months. Earlier switch may have preserved better vision because we damaged his macula. And so it has now become the drug of first choice for me in every case, whether it's a pseudophakic also. So this is another patient to illustrate a similar thing. Ranibizumab was given, vision was good, shifted to steroid, but the vision deteriorated. So gave an Eylea, vision improved to 6/12 and 12. We thought we can maintain with the steroid. So for almost 2 years, we maintained on steroid, but the vision became extremely poor. So again added aflibercept. Now you see the aflibercept is not improving the anatomy much, but within 2 injections, vision has come to 6, 9 and 6. So now he was willing to take it every 2 months, and we have been able to keep him at 2 to 3, 4 months with good vision, reasonably good vision. Decided to add a dex implant for additional effect. That did not improve the vision, though the anatomy improved slightly. So here again we had tried steroid including dex implant, and the visual result, though the anatomy was not much better with aflibercept over the dex implant, but the vision was much superior, irrespective of the anatomy. So most of my patients subsequently had to shift from dex to anti-VEGF. So now I go directly to aflibercept rather than going via the steroid route. This is a patient already tried ranibizumab. We gave aflibercept, immediate improvement in vision. He was very happy. And then we are injecting him only at 9 months with excellent vision. And then at 12 months only. And vision is N6. He's a clerk, bilateral injections. So long treatment intervals with visual results superior to anatomic results and near vision improving more than distance vision, which is what most of the patients need. Now to touch on the hard exudates, as the previous speaker, Dr. Chandramohan mentioned, systemic control is extremely important, lipids control especially, but ultimately you do also have to treat them with injections. They are more dangerous, so prevention is better than cure for these. This is a lady who came with, she had received Ozurdex already outside. When she came to me, within one injection of aflibercept, there was significant improvement, anatomy and vision, but then she was lost to follow-up for 8 months, so she again increased exudates. Again, we treated her every 2 months with marked improvement. By June of this year, there was almost no exudate, but started increasing again because she had very high triglycerides again. So that is also very important. Just injections are not enough. You have to control the lipids and sugar as well as blood pressure. But you see then, subsequently with control, everything is gone, the fluid as well as the exudates. So in 2 years, this lady, we could bring her away from the, sorry?
No, slides are not coming here. It's okay.
Okay, this is another patient, bilateral, with 2 injections of aflibercept, we could remove the exudates
Is the color
completely.
like this? Something is happening here.
The screen is not working.
भाई ऑडियो विजुअल ये इस हॉल में होता है, इस हॉल में पहले भी था, बार-बार वो आके प्रेस करते हैं.
Okay, so this is what the, so this is another patient with bilaterally 2 injections of aflibercept with complete resolution of exudates, and then we follow it up with laser for long-term effect. Another patient, bilateral, also has PDR with hemorrhage, and you see with 1 injection of aflibercept, exudates have gone as well. So aflibercept is effective in the treatment of hard exudates. Steroid is not a default therapy for hard exudates because it has complications and adverse effects. Significant resolution can happen, but it requires more intensive and longer term treatment. If you give longer intervals of treatment, there is progression of hard exudates. Now sometimes the anatomy doesn't improve, but the vision improves so much that patients insist on taking these injections. This is a patient who comes, and then finally even the anatomy improved. But the vision improves more than that. This fellow eye of the same patient underwent phaco-vitrectomy, developed edema. We gave in steroid, pressure went up, so we gave aflibercept. Again, we get a good response in a vitrectomized eye. And this effect lasts for 3 to 4 months, so which is the same as a steroid. Again, a vitrectomized eye, the effect lasts for about 3 months with a aflibercept. Most of the time when we try to give steroid in these patients, at least 30 to 40% patients, there's a pressure goes high. So now we use it as a first-line therapy, as I said. We don't really spend time with other agents. And you can see with 1 injection, the vision is going on improving, and even at 5 months, the vision has improved to N8. And the recurrence has happened only at 14 months after the last injection. And the other eye has responded like this. We gave in 1 eye, and you see the other eye with marked vision improvement. So then in all this, where to consider steroids? Only when anti-VEGFs are contraindicated, which is in pregnancy, recent cardiovascular events, severe renal dysfunction, or when there is traction with active neovascularization, because anti-VEGF can increase the traction. Avoid steroids in glaucoma, immunocompromised patients, and where the posterior capsule is absent, because it can migrate to the AC, causing an emergency situation. Thank you.
Thank you, Dr. Malika. A very well reasoned presentation where you've stated your points very clearly.
Thanks.
I would just like to know, were there cases where the cases which did not respond to aflibercept and they would have responded to, like the series you showed where the macular edema persisted? You said the patient's vision went on improving, but there was a lot of edema. Do you think this patient would have responded to steroid if you had tried it?
Yeah, Dr. Tinku, I have tried that route so many times since 2015-16. So many innumerable patients. We used to first give Dex, then go to aflibercept after not getting a response. And maybe a couple of patients I would have then tried going the opposite way. But I have never had a patient who's satisfied with Dex implant, whether it's RVO or DME. They say the vision was better with the previous one, please go back to that. So I have not had the other way around, no.
So you don't mind keeping that edema for such a prolonged time?
I can't,
why I said if you had tried
I have no
steroids.
choice. It's not that I mind, of course I mind, but I don't have a choice.
So Ma'am, you
Malika, once you say that, a lot of your patients had the effect ranging from 4 to 10 months,
Yes,
what does it mean? What does it mean? Meaning thereby patient requires every 4 or 5 months?
yes.
Does that mean the pharmacokinetics have changed? That, the duration of action has changed? Why is it that initially they were requiring, is it that you have to blast it initially and then maintaining?
Possibly the VEGF load was very high earlier, and then it starts getting neutralized, plus the patients may become more conscious, so they start controlling their systemic disease better maybe. And there is a flow and ebb with the chemicals in the eye.
So you no longer give Avastin, you no longer give ranibizumab, you only give aflibercept?
So ranibizumab, occasionally when there is a very mild edema, vision is 6-9, there we can give it, because we need only that much effect. But anything more than, worse than 6-12, or a severe looking cystoid macular, severe looking edema, I go to aflibercept, because longer action, less injections, and maybe no more injections many times.
Economically?
Sorry, sir?
Economically?
Economically, sir, most patients' economy is good. If the efficacy is good, that's economy enough. Rather than struggling with something which is not working well or coming repeatedly every month, then the economy is actually worse.
So I agree with you. I agree with you that today, world over, I think after that protocol T came up, and all of us have had wonderful experiences with aflibercept, and I may not have any doubt to say that today, although protocol T says poor vision and better vision, all these things, still I think today Eylea or aflibercept 2 milligram assumes the number 1 position in management of DME to begin with.
Absolutely.
Is that correct?
Absolutely, 100%.
one more point. Is there any role of IVTA giving with ranibizumab together in one sitting and then fill in with ranibizumab in between for patients who can't afford? So
Siddharth, you can do any jugglery what you want, but till the time you have a lot of data collection with you to show all these things. You see, IVTA went into disrepute because if there is a high pressure response with IVTA, it's very difficult to manage. You have to do vitrectomy and all. But IVTA, I'm telling you, we all started with IVTA. And all of us have wonderful slides to show the effect of IVTA also. There's no doubt in that. That a lot of people say IVTA is a poor man's Ozutrex. But IVTA does have a place in the management of...
that's what we have
Yeah,
seen.
I have a number of cases where, let me complete. Number of cases where multiple injections were taken, diabetic macular edema, taken elsewhere, with poor systemic control and no emphasis was given for control of the systems. And only by controlling the systems, the injections were totally not required for them. And they said that this is what is this miracle that has happened, that without injections I'm resolving. So in your cases, few cases I have seen SMDs are there so much that it's indicative towards the systemic derangement, which is gross derangement. Unless you emphasis on systemic control, these don't respond so well, and year after year we cannot keep doing injections alone.
Absolutely. I showed a slide where exudates came back.
Yeah. Let's move on because we have 3-4 more talks.
Thanks.
And very delighted to have Rajalingam, an old colleague at RP Center, who will now again talk about management options. As far as possible, try to avoid overlap so that we can have more discussion.
Thank you very much, sir. Thanks for AIOS and APOS for giving this opportunity. My topic is the DME management options. Slides. Excuse me. Excuse me, slides are not moving. Okay. Okay. So, because there is a lot of overlap in the topics, and just I avoid all this one.
You can highlight on the things which they have not
These are the
covered.
what are the management options available for the DME. So there are several treatment options for the DME management, and the choice of treatment depends on the availability of the retina specialist and infrastructure to deliver the treatment for the DME. So most treatment options are costly actually, and AIOS and VRSI, they have formulated their preferred practice pattern considering the different presentations of the DME in different clinical scenarios. So diverse approaches may be available depending on the location, type, and associated morbidities and complications. And there are some scenarios where the Dr. Chandramohan already mentioned that macular edema is divided into centrally involved and non-centrally involved, and the DME with other associated ocular problems, and a DME with systemic comorbidities. So before going for the management of the management options, we have to thoroughly examine the patient, take visual acuity using logmark chart, and fundus examination, that biomicroscopic fundus examination is very important, and color fundus photographs, especially the posterior pole, and if it's available, the wide field is very useful, and the fundus fluorescent angiogram, that is at baseline, to identify CNP, NVE or NVD. Then optical coherence tomography is very important tool, where you can classify whether it is a macular edema is central involved or non-central involved. If you have an option of having an OCTA, and to identify the macular ischemia is very important. And ocular examination and taking history is very important. You have to ask always the duration of the diabetes, then level, check the level of the hyperglycemia, whether the patient is suffering with hypertension or hyperlipidemia, and patient suffering with anemia or any renal problems. And at the same time, you have to take the history of the drug history, because some of the drugs can cause a macular edema, like prostaglandin drugs. So to differentiate between the CME and the diabetic macular edema. And at the same time, you have to take the history of any ocular surgeries, because cataract surgery with pseudophakia can have the same cystoid macular edema. So that you have to differentiate between the cystoid macular edema and the diabetic macular edema. So there are so many options available, steroids available, anti-VEGFs, lasers, and ultimately pars-plana vitrectomy. So steroids will act, chronic CME will act as an anti-inflammatory as well as anti-VEGF effect will be there. These are the different types of anti-VEGFs available. It is given all specifications mentioned here. And how this VEGFs act is by reducing the leakage and improve DME, and by promote rapid progression of the retinal neovascularization, and it improves NPDR, and it acts by reducing progression of the capillary closure and promotes reopening of the recently closed vessels, and it acts by causes regression of the iris neovascularization. This is the landmark studies is mentioned here, and the treatment landmark scopes where the FDA approval have come. The journey has started from the 1985 to up to here. And this is a logarithm which will give the management of the diabetic macular edema. But before the OCT comes, we have classified like a focal macular edema, diffuse macular edema, traction macular.
Because algorithm to बहुत सारा हो गया है.
Sir.
Let's come to.
Sir, this is the chart showing that central macular involvement and non-central macular involvement. When the central macular involvement, macular edema is there, you have to see the visual acuity, 6/9 or worse. You have to go for an anti-VEGFs, and at the same time, if the OCT says more than 300 micron, you have to always choose for the anti-VEGFs. And if you have if you find out any drill findings, you have to always give the poor visual prognosis even after the treatment. If the patient responds good, then you have to subject the patient for the PRN method. And if the patient gives poor response, then you have to think over whether you have to change the same drug in the same group, or you have to select the drug from the different group. So you have to give the injections monthly for 1 to 6 injections, and till the central macular thickness and visual acuity improves. And later on, you have to follow the patient every monthly for 3 months, and after that every 2 months for the 2 years. Then subject the patient for the PRN treatments. So this is a good response where 25% of the macular thickness or more reduces in after the 3 injections. Or if the visual acuity improves by ETDRA 5 letters or signals or 1 line. If the poor response is, if the macular thickness is reduces less than 10%, or less than one line improvement in the visual acuity on the Snellen chart. So fixed treatment and PRN treatment, where the treatment only performs upon the disease recurrences in the PRN one, but ultimately treat and extend is the best choice, where you can the patient can benefit in both ways. Then the patients who are non-responders to anti-VEGFs, what you have to do is, if the patient is taking the bevacizumab and not responding properly, then switch over to ranibizumab. Later on, if it's not responding, switch over to aflibercept. And many doctors prefer switch over to the
Rajalingam,
aflibercept.
there is so much confusion happening now, because Mallika says you start with aflibercept. You say you start with Avastin, then ranibizumab, then
Anyhow, time is up.
So do you follow this?
Yeah.
You follow this?
Usually, because we are working in the government sector, we usually for
Diabetic patient is same, na?
the
Government.
diabetic patient is same,
let it
but
be
we
there.
usually follow
This follow
because she has a lot of experience.
We'll
that one
go on
then-
to the question answer. Actually, Lalit, can you prepare your presentation?
Let him
Get
finish,
it ready.
finish.
No, it's
Okay.
over now.
So when to switch over the steroids, responding to anti-VEGFs, but difficult to maintain frequent follow-up visits. Second one is pseudophakic patients who have reached a plateau, that is a persistent intraocular fluid, or less than visual acuity less than 6/12, or persistent edema and needing cataract surgery. So the other conditions are occurrence of systemic vascular event while on anti-VEGFs. The other conditions are associated features such as extensive hard exudates and presence of hyperreflective dots on OCT, and ultimately eyes of post-vitrectomy also we can use for this one. Where is the role of laser in DME? So additional laser may be considered after 4 to 6 injections of anti-VEGF for the following: persistent CME with visible microaneurysms. If a switch to spheroid is not possible, that is a glaucoma or a young phakic patient, then you can subject the patient for the grid or focal laser. So role of vitrectomy in DME, where DME with predominant vitreomacular traction is there, where DME with a tractional epiretinal membrane is there, when DME with a taut posterior halide, where you can go for the vitrectomy. Then PDR with DME. Treat naive PDR should be treated with panretinal photocoagulation. In presence of extramacular traction, PRP should be done 2 disc diameter away from the traction. DME treated as a per standard protocol. In the presence of the vision threatening traction, vitrectomy is indicated in addition to the PRP. So the presence of traction threatening or involving the macula is an indication for the surgery. Anti-VEGF should be avoided in case of traction, as it can lead to worsening of the traction or Crunch syndrome. Before giving anti-VEGF in PDR with vitreous hemorrhage, B-scan should be done to rule out any traction involving the macula. Then non-resolving vitreous hemorrhage always requires a surgery. So PDR with DME in presence of the traction, a vitrectomy is indicated. In absence of traction, PRP should be done to the extent and area possible. Anti-VEGF can be used to treat DME. It may prevent rebleeding from the neovascularization elsewhere in the eye. So DME in pseudophakia. So differentiate DME from the pseudophakia. So you have to identify the microaneurysms or hard exudate that shows as a diabetic retinopathy, or if you done FFA and you find a flower petal appearance, that is shows it's a CME. So we have to differentiate between the DME and the diabetic macular edema. In presence of both DME and the CME, topical NSAID drop should be used followed by anti-VEGFs. In non-responders, switch over the steroids. DME with pregnancy. Anti-VEGFs in pregnancy is not recommended because of potential effect on the developing embryos or fetus. Wait at least 3 months after the last intravitreal injection before conceiving. Dexamethasone implant is recommended. Spontaneous regression DME is reported after delivery. So DME with type 1 diabetes. Among all diabetics, 27% of individuals with type 1 diabetes, and almost all develop diabetic retinopathy within 9 years of onset. Puberty is a well-known risk factor
Dr.
for the diabetic
Rajalingam, I
retinopathy.
request you to kindly conclude because we are very short on time now and we only have 3 speakers. You can go to your conclusion, I think.
Okay, we'll. So there are few. So in conclusion, DME is a preventable to some extent. There is a need to optimize the control of systemic factors, including hyperglycemia, hyperlipidemia, and hypertension. Care should be done holistically by multidisciplinary team with a physician, endocrinologist, internal medicine specialist, or primary care physician being the center of the patient care. Significant improvement in the management of DME can be achieved by choosing appropriate drug. Though anti-VEGF are the first line of management, coexisting ocular disease and associated comorbidities may alter the management strategies. Thank you, sir.
Okay, thank you, Rajalingam.
Thank you, sir.
Now I request Dr. Lalit Verma to speak on ERM situations and management. Before that, he already left.
Dr. Ajit. Wait. क्या करता है यार? दम लगा। So after an overdose of DMA, I think वहाँ पे तो आना। दब नहीं रहा ना? It is not showing here, na? It's not showing.
Okay, Mallika, if there is a severe anemia is there and patient was kept on hematinic, still not responding and having diabetic macular edema, you want to improve the anemia status because you know that anemia also can worsen the diabetic macular edema. What will you do?
I mean, see, it is well known that while we start systemic treatment, we can also start injections. It's not that we wait indefinitely. Definitely, we can send them to physician, wait for a month or 1.5 months. But after that, if this still not anemia is not corrected, you start your treatment as well because macula gets damaged from prolonged edema.
No. What I want to say to the audience, it is important that if anemia is existing, we should always rule out nephropathy. Rule out nephropathy because severe nephropathies, these people, unless you treat with erythropoietin, anemia less likely to get corrected. That is one point you need to keep in mind.
Shall we start?
Lalit,
thank
please.
you, thank you. Thanks to the scientific team for designing this session. And as I said, we move from DME overdose to some surgical issues. This is the current classification of interface disorders which everybody should be following now. Out of them, I will be touching only on ERM. So ERM is easily distinguishable. There's sometimes no need to do an OCT, but OCT makes you wiser. So, but all ERMs do not require surgery. Sometimes ERM may be just a OCT finding only. Stable ERMs like this 6/9 don't scare the patient that you require surgery because I come across patients who are carrying this prescription 25 gauge MYVS, but if patient is not symptomatic, please do not touch this eye. So indications of intervening in ERM is if there is a disturbing metamorphosia or drop in vision. So I'll just rush through a couple of videos here. Only thing is this system is not working here. So this is an ERM which I have stained with trypan blue and using this dye. Issue I'm facing is because it is not coming here. It is running there, but it's not coming here. चल नहीं रहा, यहाँ तो नहीं चल रहा. ऑडियो विजुअल ना इधर तो चल नहीं रहा. ओके ठीक है छोड़ो. चलो यहाँ पे चलना चाहिए ना, इधर भी तो चलना चाहिए ना. यहाँ पे स्पीड कैसे रेगुलेट करेंगे? स्पीड क्या बात है. Ajit, I will withdraw my presentation because I think this is not running here, although this, okay.
Now it's, now it is running.
Yeah, but you can't increase the speed here. No? But in any case, let me show only one video then. We'll skip other videos. This is a bent MVR blade which is being used to, tease away this epithelial membrane. And generally this membrane will come in one sheet only. इसमें तो नहीं आ रहा ना? आपको आता है? हैं? क्या करें? हाँ? ये तो किया था.
Let us not waste much time. Let the video run. Then we can ask questions.
Audiovisual has been pathetic. What to do? तुम टच करोगे ना वहाँ पे टूट जाएगा. हाथ लगा रहे हो तो फीडबैक देंगे लेकिन.
अभी तो काम होना है.
Maybe I'll think next person can present by waste time.
We will ask Dr. Uma Mahesh to present on macular hole and its management. Before he fixes his presentation, Lalit, Dr. Lalit, you are using MVR here. Will it not be harmful for the retinal surface while removing the ERM?
So, no, generally this bent MVR blade is very good for identifying. If it's a flimsy membrane, I will use a diamond duster, but if it's a well-formed mature membrane, the best way to identify is
because there is a curvature is there, and are you using 23, 27 gauge cannulas here?
generally 25 gauge.
How are you entering with this MVR?
25 gauge MVRs are available.
MVR.
25 gauge MVR we have.
Okay. Second is, after removal of the epiretinal membrane, do you stain again? Lalit?
Yeah.
After removing the epiretinal membrane, do you stain again and do the ILM peeling, or?
Not in all cases. Not in all cases, because it depends on the surface of the retina. If it looks very clean, I will not. But if there is an associated lamellar hole, or if the surface is wrinkled, then I will definitely put a BBG dye and take out the ILM.
My experience is whenever I have left the ILM, usually there is a regrowth of epiretinal membrane. To prevent the recurrence, I do a limited ILM peeling around the macular center. I think we will stop here, and I will ask Umesh to present. Thank you. Umesh, are you ready with your presentation? Okay, Uma Mahesh. I'm sorry, Umesh.
Sir, would you treat all membranes irrespective? I mean, what are the indications for treatment of an ERM?
Slides. First slide itself, for me, OCT, it's a more of an OCT curiosity. A lot of times, if the patient is disturbed metamorphopsia, then I will operate even in a patient who has 6/9 vision. But if not, then I wait for vision to drop. Patient should be actually asking for surgery rather than you scaring him that there is an ERM there and then. And Ajit Babu, I do not peel ILM in all the patients off. And I do not believe this, that all patients of ERM require ILM surgery. All of us have become ILM addicts, that we want to, remove all the ILMs, but that is not true. If it comes out, very good. But if not, believe me, do not keep scratching on the surface of the macula.
Yeah, if it's traumatic, we should
Unlike macular hole, where the culprit is ILM, here the culprit is not ILM. And a lot of times, once you peel the ERM, sometimes the ILM also comes along with it.
Yeah, when you stain, then you will see that parts of the ILM is come off and parts are not come off. That's where the cells can regrow, but it's, I think, individual choice.
So there has been a global survey conducted on ERM surgery, whether ILM surgery is required or not. And what they say is ILM surgery is not necessarily advantageous.
Not mandatory. Not mandatory, it's optional, okay. Yes, can you start without, use the microphone.
Hello.
Yes.
Yeah. Good afternoon to the dignitaries or the dais, scientific committee and the audience. So today I'm going to present macular hole and its management. So coming to the macular anatomy, this is how the foveal, normal foveal look like, and this is the foveal avascular zone. And the morphology of the fovea depends upon the arrangement of the Muller cone cells and atypical Muller cone cells. So definition of the macular hole, it is a vertical full thickness neurosensory defect extending from the internal limiting membrane to the retinal pigment epithelium, affects the central vision and causes metamorphosia. So most commonly we see this in the age group of 6th and 7th decade, more common in the females than males, and it's bilateral in the 20%, and prevalence is 3.3 in 1,000 population. Coming to the etiology, most commonly idiopathic is the most common one. Even trauma can cause macular hole, high myopias, the cystoid macular edema, and the inflammation, and vitreomacular interface disorders. Coming to the pathogenesis, macular hole are caused by the tangential traction and also the anteroposterior traction of the posterior hyaloid on the parafoveal area. So this is the picture depicting the anteroposterior traction. Macular holes are noted to be complication of the posterior vitreous detachment at its earliest stage. So Gas has described the pathophysiology there was a observation of the focal shrinkage of the perifoveal cortical vitreous, and there was a tangential traction, so which lead to the foveal detachment or the break or dehiscence at the center umbo and cause a full thickness macular hole. So the newer concept by the SDOCT tomography, there is a peculiar makeup of Muller cells in the center of the fovea. So it is a Z shape. Most macular hole develop by a mechanism of central dehiscence or a centrifugal retraction. So there is a no tearing of the foveal tissue here. It's a maximum extent of the progression centrifugal retraction of the foveal photoreceptors is up to 400 microns. So gas classification by the slit lamp examination, stage 1 has 1, 2, where we see yellow reflex, and the yellow ring depends upon the lipid lipofuscin distribution. And here the vision is normal. The patients may be asymptomatic, and this is the OCT picture which depicts. Coming to the stage 2 macular hole, thickness is less than 400 microns in size. So on OCT, if you see the posterior hyaloid, it may be detached at the one edge. And the patient complains of a pincushion effect. Stage 3 macular hole is a full thickness of size of 400 microns. Nearly 100% of stage 2 will convert to stage 3. The posterior hyaloid here, it is completely detached, and we can see a operculum, but it is still attached at the optic disc. So coming to the stage 4, the posterior vitreous detachment is also seen at the optic disc. So international vitreomacular traction classification on the OCT, we have vitreomacular adhesion, traction, and the full thickness macular hole. In vitreomacular adhesion, there is a no distortion of the foveal contour. It can be a focal or a broad, depends upon the addition of whether it is 1500 microns or more. So in vitreomacular traction, there is a distortion of the foveal contour. So this is the article. So coming to the diagnosis, by direct ophthalmoscopy, we can see and diagnose macular hole and slit lamp biomicroscopy examination. And if we do a Watzke-Allen test, where we can see a defect in the center of the, if we project a slit beam, we can see the defect. On OCT also, we can make out the macular hole. Differential diagnosis, a lamellar macular hole and a pseudomacular hole. In lamellar macular hole, there will be a loss of internal tissue here, inner retina, and the pseudomacular hole, there is no loss of inner retinal tissue, where we can see a epiretinal membrane with cystic spaces. Coming to the prognostic factor, it depends upon the preoperative visual acuity and the duration of the macular hole, stage of the macular hole, pre-op lens status, and the hole formation factor. Value higher than 0.5 better results, and the macular hole index more than 0.5 have a better visual outcome. Principles of surgery is we have to release the anteroposterior traction by complete vitrectomy, and release the tangential traction by removing a retinal membrane or internal limiting membrane and increase the elasticity of the retina, and retinal tamponade by a gas or silicon oil and reoppose the retina. Coming to the management, stage 1 is an observation. Stage 2, 3 and 4 we have to do a surgery. So I'll show you surgical videos. So we do an anterior vitrectomy after 3 post-vascular vitrectomy.
I think we will skip the videos because we are already exceeding the time allocated for this session.
Yes, sir.
You give the conclusions.
So in this I most commonly prefer inverted ILM flap technique, do a fluid air exchange and tamponade with the gas 12 to 14% C3F8 gas. So complications we see feathery cataract, nuclear sclerotic cataract, visual field defect, raised IOP. If the gas is more, we can, like other retinal surgeries, we can see any retinal tears, segmatogenous detachments and so on. So there are other surgical options where the recurrent macular holes are there. Either we can put an autologous serum or lens capsular flap or autologous retinal transplant or human amniotic membrane. Thank you, sir.
You have mentioned several prognostic factors. Nowadays, do you consider that they are playing significant role, or certain times even if the patient not fitting in, since we are almost achieving the success rate of 95 to 98%, will you take others which are outside this prognostic factor?
Definitely, sir, because we should not aim for the anatomical closure. We should aim for the functional closure. For functional closure, until unless there is an intact ISOS junction, then only the patient will have an improvement in the vision. Otherwise, even if the anatomically macular hole is closed, the patient will not have improvement in the vision in a chronic or large macular holes.
Yeah, means in the inverted flap technique, means previously we used to cut the duration of macular hole. Now we are not considering that. Second, size of the hole also you are saying inverted flap, but a smaller hole without flap, the visual results are better and the closure rates are equally good. So you should not go for inverted flaps in smaller holes. Third is that if hole is large, you still close it because the parafoveal area can be certain times useful to improve the central vision that may be useful for the patient. With this, I think short this thing. Are you ready, Ravikiran?
Yes.
Yeah. Ravikiran will ask only questions, I think, and he has thought nicely that instead of presenting diabetic macular edema again, we will go on to the panel, I think.
Thank you very much,
But make
sir.
it short, only 5 minutes.
Sure.
And
Very
to the
good.
next, whoever is there, the session, we received 20 minutes late, but we are trying to finish within that 5 minutes extra time.
Yeah. Very good afternoon, all respected seniors and my dear friends. As there is already a lot of discussion earlier on the management of DME options, so I just tweaked my topic into a few frequently asked questions with the experts.
Dr. Lalit Verma requests you to please come and join.
So as we all know, DME is the most common cause for the defective vision in working class population, so which affects the finances of family badly. And we are, India being diabetic capital of the world, we see a lot of patients in our day in and day out practice. So my first question to the panel is like, what is the role of FFA? Like, do we do this as a baseline to all the patients who are presenting with DME, or just before the focal laser only to identify the leaking macular aneurysms, or only in cases of non-responders? So,
Yeah, I think non-responders, where we start thinking that we may have to do laser.
The two situations are there. One is the visual acuity. You are doubtful that there can be some kind of ischemia playing a part. Probably FFA is the best investigation that you need to do. Otherwise, I agree fully with Malika that beginning it is not required, but if non-responders and those cases, you should.
No, I will do FA when the patient is coming for the first time in all of them.
As a
There is
baseline,
there
sir?
is a
As a
reason,
baseline.
as a baseline. There is a reason for that, because so many times, it's not one time, so many times, we have picked up non-perfusion area or CNP areas or neurostimulation elsewhere. You see, if the OCT is raised, maybe I'll not, but if the OCT is not, then 100% FA. You see, baseline, three things have to be done, irrespective of when a patient comes. Especially it is more than moderate NPDR. If more than moderate NPDR, you should always.
You need to further qualify while doing now.
Yeah,
I agree.
obviously not a patient who has one or two aneurysms, not in those patients. Mild NPDR exclude.
Let's go to the next question because only 5 minutes.
Okay. There are only 5 questions. The second one is about the dosing regimen of anti-VEGF in the treatment-naive patients. Is it always a loading dose followed by PRN, or is it right from the start of the treatment, is it a PRN or treat and extend regimen?
So I think loading dose is not really required. So you can just go with PRN and dosing, and as the CATS trial has already shown that, as we were discussing now, you give loading doses, eventually the eventual outcome is no longer different. So you can go with the PRN dosing.
Yeah, think.
Yeah, same. I also follow a PRN strategy.
So go to the next question.
Loading day is only for ARMD.
Okay.
So my next question is when to switch the agent. If you see non-responders, will you switch even after a single injection or after 2 injections, or you proceed with 3 injections or later?
Number of choices you are given are less after it is 2 or 3 injections.
2 or 3.
2 or 3 injections.
3, at least 3.
Yeah.
Okay.
Yeah, 2 or 3 I said, because if maximum response will occur in 2 injections. You see, if you see all the graphs, 1 injection graph goes like this.
Next.
Then after 2-3 injections it maintains.
Next.
Okay. Moving on to the next question. Will you ever start a treatment-naive patient if it appears as a chronic DME and OCT on a steroid, or only after trial of anti-VEGF?
I think ma'am can.
So in any case, I will, sometimes if a patient is pseudophakic or about to become pseudophakic, I may start steroid also. Because it's not always necessary that you always start with anti-VEGF.
So yes, in chronic cases, patients who have very large cystoid spaces, a huge amount of edema, I know the anti-VEGF alone will not be able to take care. So in such cases, I definitely start with a steroid. Even in phakic patients, because if 1 injection or 2 injections generally don't sometimes cause so much cataract, we need to take care of the edema more.
I think
so I do use steroids as first line.
I think, sir, and Dr. Tinku, I think maybe you are comparing with the previous generation, with ranibizumab, let's say, but the newer anti-VEGFs, they are not inferior to steroid, as I showed so many cases.
No, the cases you showed still had recalcitrant edema. And so,
but
like you said,
many of them
edema
responded
is
to
going
aflibercept.
Yeah,
They did not.
the choices between steroid and
Newer
newer
anti-VEGF.
anti-VEGFs.
Yes.
Okay. Next question, please.
Yeah, when coming to the cataract with coexisting DME, what will be the management option? Whether you treat DME first, followed by the cataract, or treat simultaneously, giving the anti-VEGF injection at the time of cataract surgery, or first treating cataract followed by DME?
DME first, because it can become recalcitrant because of the surgery itself.
Simultaneous. Previously means you should dry the macula first and then go for cataract.
Always DME first.
Ideally.
Okay. Last question. Any role of combined anti-VEGF and steroid?
Maybe.
With the newer anti-VEGFs, there's hardly any role. I showed the cases also. But earlier we used to do with Avastin, we used to add triamcinolone, but not now.
Okay.
Generally answer is no. Generally answer is no.
Right? This is the last question.
Yes.
Yeah, thank you very much, and thank you audience for your patient listening, and I thank all the co-chair for a lively session. Thank you all.
Thanks, sir and Dr. Ajit Babu.